therapy immediately after TURBT has been advocated since the 1970s and is now considered the gold standard. And the rationale for single-dose perioperative instillation includes the destruction of residual microscopic tumor at the site of the TURBT and of any circulating cells, thereby preventing reimplantation at the time of TURBT. To clarify this, there's been a meta-analysis performed including 7 randomized trials, each evaluating the clinical value of a single immediate instillation of a cytotoxic agent, and has noted a almost 40% decrease in the odds of recurrence with chemotherapy. However, in cases where bladder perforation is suspected or in cases of gross hematuria, an immediate instillation should not be administered, as this may result in chemical pericystitis. This is the meta-analysis comparing intravesical chemotherapy to TUR alone, demonstrating that chemotherapy prevents recurrence but not progression. It is still controversial how long and how frequently intravesical chemotherapy to be given in the patients who have low-risk disease. When evaluating the difference between BCG and chemotherapy, more recent meta-analysis shows that BCG given with maintenance therapy should be offered to patients who did receive single-agent perioperative chemotherapy as a second step of gold standard regimen. Even though BCG has been used for some considerable time, the optimal dose and schedule has yet to be determined. However, all this evidence tends to suggest, although more toxic, that BCG has superior activity compared to mitomycin C for the prophylaxis of tumor recurrence in high-risk patients. Intravesical BCG certainly has an impact on recurrence and progression. Typical induction regimens are 6 weeks compared to 6 weeks with maintenance therapy for 3 weeks on a Q6-month basis for 3 years. All maintenance regimens do differ, but maintenance therapy does offer a 20% improvement in recurrence-free survival at the 5-year mark. There are some significant side effects, however, noted with BCG, including potential for fevers, chills, hematuria, potential for BCGiosis. There are certainly some urinary side effects causing overactive bladder symptoms. And of patients offered maintenance therapy, only 16% of them are actually receiving it at 3 years post-induction time. It is suggested that 1/3 of a dose may be equal in efficacy while minimizing some of the side effects when compared to full-dose BCG. Turning over to the carcinoma in situ category, up to 50% of patients with CIS will progress to T2 disease and 10% will have metastasis. BCG therapy is considered the mainstay of therapy for this disease category, and up to 70% of patients will have a response. In patients who've had a BCG failure, repeat use of BCG with or without interferon therapy, the use of valrubicin or Valstar can have some impact. There's a 20% response rate in patients who've had BCG failures and given valrubicin, and certainly this is a good option for patients who are poor surgical candidates and cannot undergo radical cystectomy. In addition, I believe this is an excellent disease category for enrollment in any available clinical trial. Intravesical treatment failures who've been given intravesical chemotherapy first can certainly benefit from the use of BCG on subsequent intravesical treatment. If BCG therapy is given, however, you can be considered to have a failure if there are higher number of recurrences, if there's increased grade and stage migration, or there's concomitant CIS at the time of recurrence. If you have high-grade disease at both the 3 and 6 month recurrence, an additional course of BCG can provoke response at the 6 month mark. Take that back. In patients who've had intravesical treatment failures, if chemotherapy was given initially, they can certainly benefit from BCG therapy on a subsequent installation. However, if BCG therapy was given first, they can be considered to have treatment failure if there's higher number of recurrences and there's increased grade or stage at the time of recurrence, or there's concomitant carcinoma in situ. Certainly, they're considered a failure if they have muscle invasive disease. In patients who have high-grade disease, an additional course of BCG at 3 months can actually provoke response in up to 50% of patients at 6 months. So if you do have high-grade recurrence after an initial induction course with BCG, I would say that a subsequent induction course can have a significant benefit in some of our patients. In terms of a surveillance plan for patients with this disease category, the high frequency of local recurrence and the potential for stage progression, especially for high-risk disease, highlights the importance of vigilant surveillance with cystoscopy in all patients with non-muscle invasive bladder cancer. A clinical follow-up involves an appropriate patient history, including voiding symptoms, the presence of hematuria, urinalysis, cystoscopy, and urine cytology. Cystoscopic and cytology exams should be continued every 3 months for 2 years after the initial diagnosis, then subsequently expanded to every 6 months for another 2 years, and then annually thereafter. Annual upper tract imaging by either retrograde palograms or CT urograms should be performed to assess for ureteral or renal pelvis involvement, as there is a 5% risk of developing this down the line. And at the present time, the use of and utility of urine-based molecular markers in the follow-up of patients remains uncertain. Most of the current markers in use have higher sensitivities than cytology, especially when used to identify low-grade disease. But all of these tests must still be utilized in conjunction with cystoscopy and the cystoscopic findings. A complete elimination of cystoscopy or cytology to detect bladder cancer does not appear feasible, at least not in the near future. One or more of these tests may eventually prove to be a useful adjunct for cytology and cystoscopy, but each and every one of these markers awaits further validation. I'd like to mention something about a new optical imaging agent, which is Cysview. It uses hexaminolevinate hydrochloride, which is indicated in the cystoscopic detection of non-muscle invasive papillary cancer among patients who are suspected to have lesions on the basis of a prior cystoscopy. And so Cysview is used to perform cystoscopy with the blue light setting, which is these pictures taken on the right, as an adjunct to white light setting, which is shown here on the left. So these are the same exact areas with these slightly discolored pink areas, biopsy proven to be disease that may have not been clearly visible in white light visualization. So in conclusion, non-invasive bladder cancer really accounts for two separate disease processes. Low-grade TA disease, which is bothersome but certainly treatable and does not have a high risk of progression. And then on the other hand, it includes non-invasive bladder cancer, also includes T1 and carcinoma in situ, which can be considered to be life-threatening and require lifelong surveillance to rule out any progression of disease. We certainly have needs in this disease category. We need less invasive follow-up and certainly better interventions for high-risk disease. And I do believe this is an excellent patient category for enrollment in a clinical trial. With that, I'm available for any questions and contact with the above telephone number and email addresses provided on this slide.